Good evening, everyone. This is Rebecca Schrook from the Office of Alumni Relations. We're going to give everyone a little bit of time to log in, so we'll start the presentation around 7:35. Thank you. Louisa, Dr. Goldberg, can you hear me okay?
Hi.
Yes, I can hear you.
Good. Good.
Hi, Dr. Goldberg.
Is that Rebecca?
This is Louisa, and Rebecca's on the line.
Oh, okay. I thought the voice changed. I'm sorry. We got 19 early birds already? Wow.
All right, good evening, everyone. This is Rebecca Shruk from the Office of Alumni Relations, and I want to thank you for joining us on this Tuesday evening. Just a few notes before we get started for the webinar. If you're joining us by telephone, just please make sure to mute your phones. And then, of course, feel free to submit questions throughout the presentation using the question box. Questions will be asked at the end of the presentation. So I will read them to Dr. Goldberg and he'll be able to answer them. Also, I did have a question just recently. Unfortunately, we do not offer any C&E credits for our webinars. This is just some wonderful lifelong learning for us all. So let's get started. Tonight, we have more than 133 alumni from both our Center City and East Falls campuses joining us tonight, representing all the colleges, 24 states, and Canada. So here's a great little map of where everyone's coming from this evening. And then also joining us this evening is Louisa Kopp from the Office of Alumni Relations, and Louisa is going to talk to you about some of our upcoming events. And Dr. Goldberg.
Hi, everyone. So we have lots of events coming up this summer. Starting with June 13th, we have in Radnor, if you're in the Philadelphia area, we have our presentation on Jefferson and the Vietnam War. And then you can see a bunch of other things that we have coming up. And we're also starting to plan our calendar for the fall. So if you have any ideas or suggestions for us, please let us know. We always love to try to have new events. So we're open to hearing all of your ideas. I'm very excited and pleased to introduce our speaker this evening. Dr. Robert Goldberg is the Chief Medical Officer and Senior Vice President of Healthesystems. He is responsible for providing strategic direction and oversight for all medical aspects of the company, including both the pharmacy and ancillary benefits management programs. Dr. Goldberg is a Jefferson Medical College graduate, and he's board certified in occupational medicine. He was a full-time professor of medicine and occupational medicine residency program director at the University of California in San Francisco. He has over 25 years of medical management experience, having worked closely with payers, employers, third-party administrators, and patients. And he also has over 20 years of experience treating injured workers in private practice. He's renowned for his contributions to the field of occupational and environmental medicine, and he has extensive experience in evidence-based medicine and epidemiologic research. He is a frequent speaker at industry and medical events, both nationally and internationally, so we're very happy to have him tonight. Thank you, Dr. Goldberg.
Thank you, Louisa and Rebecca, for inviting me. It's a pleasure to be here. Let's get started. And it's great to be talking to fellow alums at Jefferson. I'm going to throw in a plug for the winter update. It's a ski meeting. This year it's going to be in Vail, and I've gone the last 3 years, and it's been fabulous. And I actually gave this talk, or a version of this talk, in February at the meeting at Snowmass. So if you're still a skier, look for that and come on board. Okay, let's see if I can get this moving. There we go. So our agenda is, I'm going to start with some description of the epidemiology, then go into what's happening at the state and federal level, or what's not happening at the state and federal level, and then get into what prescribing physicians can do to help make the problem better, as opposed to where it is right now. So here are the numbers. The numbers are pretty grim. Total drug overdoses in 2016, according to CDC, were 63,600. So a mere 42,000 were only due to opioids, which is a huge increase year over year, really for the last decade or more. And as you can see, we hit a real milestone in 2016 in that for the first time, opioid-related drug deaths have exceeded breast cancer deaths. And the irony is, we've had, declining breast cancer deaths for the last 20 or 30 years, or maybe even 40, but at least 20 or 30. But we still have all kinds of foundations and research and marches and fundraisers to support either breast cancer treatment or research. But I don't think we ever see any marches or great efforts to reduce this public health tragedy of 42,000 deaths. And I don't have the numbers for 2017 yet, but there's no reason to believe that the numbers have gone down as yet. And I don't know when the peak of this epidemic will occur. I don't think anyone can really predict it. And then the other startling statistic is that life expectancy for the last 2 years, where numbers are available, has dropped, and specifically related to drug overdose deaths and specifically related to the opioid epidemic. So let's look at what the curve looks like. And what you can see in the red line is that total opioid overdose deaths has continued to climb since the earlier part of the decade, and has now ramped up, not quite a hockey stick, but nonetheless increased slope of growth. And as you can see, most of that growth is more than likely due to the yellow line, which is related to non-methadone synthetics, namely fentanyl. And fentanyl is certainly becoming the scourge in communities where there's already an underlying heroin epidemic secondary to the prescription opioid epidemic. So this is extremely alarming. We should be doing better, and we're going to continue to look at some more numbers on the next slide. So what we can see here on the right-hand chart is that the number of prescriptions per 100 persons in the United States, and we peaked in 2010 with some small blessing of 80. So almost one prescription per adult in the United States, which is just amazing if you think about your own practice and just think about our population, that over the course of a year, almost every adult would have received an opioid prescription. Now, of course, that didn't happen because that's an average just over the population. But nonetheless, the numbers have nearly declined to just under 70 per 100 in 2016, and that's the last year of available numbers. Next is morphine. MME is morphine milligram equivalent. We sometimes use MED. You may see that as well, which is morphine equivalent dose. Really the same thing, same calculation, and takes into consideration the potency of the medication and the number of pills that any individual would have at any one time. And again, what you can see is back in '99, when our good friends at Purdue Pharma were really starting to get traction and launch OxyContin, you can see the upward ramp from MME or MED just under 200, where it peaked at close to 800, which is just astounding. It's backed off a little bit. I mean, that's the good news. The not so good news is at least according to this chart, it's flattening out at right around 600. But frankly, if it were to drop another 10 or 20% down to 500, it's still an enormous load in our population in terms of the amount of opioid that's circulating in our communities. Oops, I want to go back, sorry. The other number that's important is the day supply. And so day supply is really calculated on if you give somebody 30 pills and tell them to take it 4 or 5 times a day that's roughly a 6-day supply of medication. And what you can see is that the average MED was 13 12 years ago. And so people were getting, if they were taking 4 a day, they were getting at least 50. And of course, if they were taking 8 a day, they were breaching 100. So how many of us, used to prescribe, Vicodin, oxycodone, or Percocet, 60 or 100? It was probably pretty routine in the 90s and 2000s, unfortunately. And the bad news is this day supply number actually has continued to climb, which is not a good marker for success. So now I'm going to go into what's happening at the state and federal level to either acknowledge the issue or start to address this burgeoning epidemic. So a number of states have started to recognize the issue, and what you can see here is that I picked just some representative states. Tennessee in 2016, had a huge prescribing rate, 107, compared to the national 66, so almost 2-to-1 ratio. Pennsylvania, a little higher than national, not as bad as Tennessee. And then when you go down the left-hand side of the chart, you can see that in New Jersey it's a little better than Pennsylvania, and then Massachusetts significantly better, and California is the lowest on the chart. And we can wonder why this is the case. And certainly Tennessee and Appalachia have been ground zero for the epidemic, and that's why the numbers are high. But they also have become an early adopter of prescription drug monitoring programs, and so they're starting to drop off, and you can see the reduction just from 15 to 16 was 6.5%. At the bottom of the chart, California has continued to have a reduction, but one has to wonder why it's been historically lower than most of the states. And I think many people, including myself, would tend to have the inclination to believe that's due to the fact that California has had medical marijuana on compassionate use basis since 1996. And there may be other factors in play as well. Nonetheless, a number of states are taking action. Massachusetts also adopted a 7-day prescribing limit in March 2016. And in 17 and 18, other states are taking action as well. And the actions range from a number of days of medication to number of pills. No state has actually mandated a hard MED, although many are coming out with guidelines to stay under 50 in accordance with CDC recommendations. But I think you're going to see this going forward. And unfortunately, in the Commonwealth of Pennsylvania, there was a formulary bill to apply to workers' comp, and it passed both houses in the legislature, and the governor was persuaded by a number of influencers that this would be bad for injured workers and bad for labor, and I guess bad politically, to actually take steps to curtail not only opioids, but excessive prescribing and polypharmacy for injured workers. I can editorialize on that later if anybody's interested. So we'll go to the next slide. I apologize. I have a lag. I don't know if you guys have a lag out there too, but I'm on the West Coast. I'm in the San Francisco Bay Area, and as fast as the internet is, it's still not instantaneous. So what's happening at the federal level? At the federal level, there was an act signed called the Cures Act, and it's had some updated funding. Most of the Cures Act had actually very little to do with opioids, had more to do with fast-tracking through the FDA, but nonetheless, it did have a little bit of money set aside that hasn't been used yet, which is really a travesty. The funding was $1 billion total for any opioid initiatives, and this could be to support state activities, start to do some training of healthcare workers, and also try to support some research at NIH. Now, the sad part of this whole thing is that the Council of Economic Advisors, the federal government, reported that the total epidemic probably costs $500 billion a year, and we're spending $1 billion to address it. And just to put it into perspective further, Francis Collins, the director of NIH, estimated that to do proper research, it would take about $500 million a year, so that would be half that $1 billion. And to contrast that $500 million that should be going to NIH for research, but isn't. When Purdue was really ramping up their advertising and marketing and promotion campaign in 2001 alone, they spent $200 million on marketing and promotion of OxyContin, and forget about any other manufacturer of opioids. So this is a drop in the bucket. A drop in the bucket is better than nothing in the bucket, but there's much more we have to do in terms of research on opioid use disorder, on prevention, as well as various interventions, and of course, training us to do a better job in treating pain and treating people who do have opioid dependency or use disorder. Okay, so what's happening at the FDA? So the FDA has aided and abetted this epidemic beautifully for the last 20 years after first approving MS-Contin in the 80s, and then OxyContin in the 90s. Then there was this real gold rush of opioids by numerous manufacturers. There are now over 40 opioids on the market of all kinds of formulations. They're extended release, intermediate release, so that's the IR and the ER. And then there's this formulation that I'm going to say is the so-called ADO, or abuse deterrent opioid, which is basically another way for manufacturer to put their own packaging and spin around oxycodone or morphine, hydrocodone, and then claim that it's harder to divert that drug to melt it down or crush it or use it in an abusive situation. And essentially, they haven't really addressed the problem. And in fact, if you just recall that they still come in a pill, doctors prescribe them, pharmacies stock them and dispense them, and majority of people, if they're not selling them to someone else to take orally, they're taking them orally. So abuse deterrence doesn't deter anyone from getting a prescription, filling it, and taking it. And so the only abuse deterrence really that's available with these medications, in my opinion, is not prescribing them and not taking them, because we have plenty of generic medications that can be used in small quantities that, one, don't cost a lot of money, and number two, can be prescribed very easily in very small quantities. So a miracle happened in June 2017 in that the FDA started to wake up, and you can see right here in the middle of the slide, Opana ER was removed from the market in response to a request by the NIH, by the FDA. This is the first time an opioid was actually been removed from the market for safety concerns, which is just absolutely amazing. In the meantime, they fast-tracked one biological opioid medication for pain, which of course will be extremely expensive because it is a biologic, much like Humira and other biologics. It won't be cheap. And then the FDA generally said that they were becoming concerned about abuse deterrence and whether or not abuse deterrent opioids really were addressing the problem. And then for the first time in the fall last year, this agent, just one more oxycodone extended release formulation called Rexista, was actually not approved. And so this is, I don't know if we should call it the low water mark or the high water mark, but nonetheless, this is a milestone. FDA actually did not approve a new application for a Me Too opioid. And then they've also talked about expansion of REMS, which is simply a program that manufacturers are supposed to put out there for prescribers, and the acronym is Risk Evaluation and Mitigation Strategies. So it's an education and training program for physicians who prescribe drugs. The manufacturers were required to do it for all extended release or long-acting formulations, and now the FDA is, I'm not sure if they're asking or telling manufacturers to include all immediate or short-acting opioids. That's the IR formulation. So the organization that is supposed to prevent disease and step into epidemics has been very slow in coming, but finally did publish guidelines in March 2016, primarily targeted to primary care prescribers, but certainly medical and surgical specialists are not immune to this guidance. And basically there were 10 recommendations, and they were grouped into deciding who really needs an opioid, what's the right opioid, how to decide on the dose, how long, and how to manage treatment, and then how to assess risk and also address any side effects or any harms. And I think the number one message I would have in relation to the CDC guidelines, and I'll reiterate this later, is that the best opioid for a patient is the one you don't prescribe, but if a patient has failed other forms of pain management, then it should be the lowest dose and for the shortest duration possible after other methods have failed. And then I would concur fully that you should keep the dose under 50 MME, and the CDC recommends avoiding going over 90. 50 MME should take care of most patients. And why is it 50 and why 90? Because what happens is once you breach 50 MME a day, then the risk curves for death and other complications and morbidity starts to take off. And then by the time you get to 90, that curve is really starting to ramp upwards. And then for acute pain, there's a lot of cases, if people actually do need an opioid, a 3-day prescription is more than sufficient. And remember, a lot of the opioid use and abuse and misuse is actually occurring due to the fact that plenty of people of all ages get excess quantities that then sit in a medicine cabinet or in a drawer that become available actually for other people to use and abuse. Okay, so what can we do as prescribing, treating physicians? So it's really easy to write a prescription for anything. It's easy when antibiotics were being used for everything, to send the patient out the door with penicillin and ampicillin for their sore throat or their earache. Much easier to do that than to argue with a mom around how most sore throats and most earaches are viral and they won't need it. Same thing with pain. it's much easier to not argue with a patient and just simply give them a prescription for Vicodin, and then they're out the door. They're happy. They got the prescription that hopefully they were expecting, or they were expecting hopefully, and you're on to the next patient, and they're happy. And even if they have no history of use or abuse, they're supposedly taken care of. But there is good research to show that the sooner in the treatment of acute pain or a chronic pain disorder, patients get the first opioid prescription, it markedly increases their risk for chronic use, and then increases the risk also for abuse. Opioids have good evidence of efficacy for acute pain. There's actually no good research that shows that for most non-cancer, and again I stress non-cancer pain disorders, which are the majority of disorders that are being treated with opioids, that there's no long-term evidence of efficacy. It's more a matter of tolerance, dependence, misuse, and ultimately addiction. So how do we avoid that, and how do we treat the patient in a more holistic way anyway? And that's really a comprehensive approach. So, know your patient, understand the psychological and social determinants that are present with the patient. Think about what comorbidities might be present, be it physical or psychological, that might increase the risk to the patient for use of an opioid. We think about respiratory depression when people with chronic lung disease, but we should be thinking about depression, anxiety, fear avoidance behaviors that predispose people for continuing opioid use. And then let's not think about pharma as the first answer to pain. A lot of injuries, and I'm sure a lot of physicians on this call and around the country know how to self-treat without any medication, and usually probably start with simple doses of acetaminophen or ibuprofen. There's no reason we can't start that kind of approach with our patients as well. And if patients are off work for whatever reason, it doesn't have to be a work-related injury. Getting people back to work, no matter what cause of the pain or the injury, is very therapeutic. It's part of the rehab approach to injury and to pain management. So I want to talk for a minute about the biopsychosocial model. It's become very much in vogue, so many of you may be aware of it, and I'll apologize in advance to some of you who may be as familiar with this, or maybe even more familiar and expert than I am. So essentially, Gordon Waddell developed this model to address low back pain, and I'm just going to run through quickly a few key points in the model that he developed. So of course, patients typically will come in with some physical pathology, so it'll be back pain or a neck injury, or frankly, a sprained ankle or a broken wrist. And so, pain is experienced both at the direct sensory level, but it's also an emotional experience. And I think we all know that patients have varying pain thresholds, but also varying emotional responses to pain. These pain responses are due to a variety of factors, including past experience with pain, but also what they believe around pain. And for some people, pain is an annoyance and it's in the way, and they set it aside to be able to continue to function. For other people, pain is something that they believe is a signal that they shouldn't do anything, because if it hurts, don't do it. We have to also consider the underlying psychological concerns. Is there a fear of further injury, fear of past injury, other psychological issues that may be playing out that have nothing actually to do with the injury? And then there's the genetic component to how we experience pain. And so it's pretty hard to measure that, but I think we need to be aware that there is an underlying genetic component. And then the whole socio-environmental factors. So what's happening in the household? Are there life stressors? Are there workplace stressors? What's going on that may heighten the awareness of pain or cause the patient to express all their other issues and concerns through the complaint of pain that they are truly experiencing. But their pain is not due to the specific injury. It's a deeper, more fundamental pain that they're experiencing, and those have to be addressed or at least recognized. So this is a very interesting study as it relates to opioid use and mental health conditions. So people who actually have diagnosed mental health conditions use 51% of all the opioid prescriptions in the United States. And of course, the population that's diagnosed with mental health conditions probably no more than about 10% in the country. Probably 20% have mental health conditions, but half or less actually are diagnosed. So this is a huge disproportionate burden. And then if there is a diagnosed condition, people are 3.5 times more likely to use opioids. So again, the risk factor is huge. You want to be aware of any mental health, either diagnoses or conditions that might be increasing the risk of your patient, not only to use them, but then to misuse them and lead to dependency, if not tolerance and addiction. And the highest risk predictors, according to this study, were, as you might guess, anxiety and depression, so catastrophizing, and fear avoidance is the other common issue as it relates to pain, opioid, and loss of function. So what can we do for patients besides prescribing medication, let alone prescribing opioids? So it gets back down to understanding the patient and then helping the patient take care of themselves. So how can they cope with pain? How can they cope with their injury in ways that simply don't rely on medication? So we have to educate them, we have to spend time with them, and then the patients really have to be empowered to be able to take care of themselves with a variety of modalities that I'll mention in a minute. But we also have to address any negative thinking and negative behaviors, pain-seeking behaviors, fear avoidance behaviors, and again, getting back to catastrophizing, where people just don't believe they're going to get better, they need more pain medication, and without pain medication, they can't live, they can't function, and so forth. And so the sooner we can recognize these issues and then cut them off, the better off patients will be. Oops, got one click too many, sorry. So what can patients do in terms of self-care? And so I put these into 4 buckets. And so simple applications of ice acutely, heat later. Some people prefer heat right away and only heat. Some people prefer cold right away and only cold. And some people like alternating hot and cold, depending on the injury and what their experience is. And there's actually no good research that says it has to be in a certain order for a certain duration, as much as we might have been taught otherwise. But anyway, applications of hot packs, cold packs, ice packs, hot wet towels warmed up in the microwave, so less than scalding temperatures, often go a long way. Over-the-counter medications, again, I mentioned earlier, simple things like acetaminophen, ibuprofen, naproxen, often are more than sufficient to take care of the problem. Most of those are able to be taken without a prescription, over the counter, and you can advise them on how to vary the dose based on the OTC preparation. And then there are some topical medications that actually are useful. Certainly capsaicin is a really good example, and there are some inexpensive preparations of topical lidocaine as well. More active programs help people recover, and better yet are good prevention tools, both primary and secondary prevention, in that people that are generally more aerobically fit, and more fit in terms of their musculoskeletal condition, will recover from injuries or even potentially be at less risk for injury. But if they are injured, getting them back into a more active program. Simple walking programs for many injuries, including neck and back pain, are very useful. Getting people moving is very useful, but also stimulating the endorphin system with mild aerobic activity is, of course, a non-pharmacologic way to address pain. And then various relaxation techniques, be it breathing techniques, meditation, biofeedback, and massage are all very useful for some patients. And you don't know who it's going to work for until you try it. So this is a slide. This is our pain management pathway that I'll run through to try to summarize all the approaches to treating pain. So starting over here on the left, I started to mention non-pharma therapies. So in addition to the self-care that I talked about a minute ago, certainly physical therapy, OT, is very useful on a limited basis to help people not only recover strength and function, but also to teach them more about their condition, teach them more about their body. And then most physical therapy programs that are successful ultimately lead to patient education, self-care, and home exercise programs. And so programs don't have to be intensive, nor do they have to be necessarily lengthy, unless, of course, we're talking about catastrophic injury. Acupuncture works for some patients. It's a short trial for 2 or 3 visits a week for the first 1 or 2 weeks. If that works, then try it for another couple weeks. If it doesn't work, stop. You usually haven't lost much. Yoga has been shown to be very effective for pain, not acutely, but for chronic pain, particularly chronic low back pain. And then CBT is cognitive behavioral therapy. There's excellent evidence that CBT is very useful for the treatment of pain, chronic pain, catastrophizing, where people are able to really start to understand more about their condition and that they can take control and they can visualize situations where they're no longer experiencing their pain and become way more active. And usually a few visits with a skilled therapist who's trained in CBT is all it takes. And then patients really can do this on their own. So it's not a big deal in terms of commitment to large number of visits or dollar expense. In terms of non-opioid pharma, so talked about NSAIDs and acetaminophen. So for certain patients, low-dose antidepressants are valuable. And then people who clearly have underlying depression can be titrated up to antidepressant dosing, which will then, in a primary and secondary way, address their pain. And then there's limited evidence for neuropathic pain agents. And just a word on these for a second, in that most of the research on gabapentin and pregabalin, otherwise Lyrica, these agents have been studied primarily on diabetic neuropathy and chronic pain disorders related to that. And so the evidence is there. It's been extrapolated back to non-diabetic pain disorders that are considered neuropathic. And there's limited evidence of efficacy, but for some patients, it makes a real difference. So you have to start at a lower dose and then titrate up very carefully. There are side effects, but a number of patients can respond to it. Opioids, I think we talked about it considerably already, but basically a number of states require, and if your state doesn't require, I still think it's a really good idea to check the PDMP or Physician Drug Monitoring Program. You'll get at a minimum, the opioid prescribing history for that patient, because you're not going to get the full history. Patients forget, or they don't want to disclose what their opioid use history is. And they usually use multiple pharmacies. So, calling your local CVS or Walgreens or Fred's local corner pharmacy, you may not get their full medication history anyway. doing a risk assessment, much as I've discussed before, and then developing a plan of therapy. So once you start to prescribe, you need an exit plan in your mind on the way in, and not try to figure it out 1, 3, 6, 12 months later, because you'll be behind the curve in terms of managing that patient's opioid use. So beyond a few days or a few weeks, start considering an opioid agreement where you set terms and conditions with your patient. So as you're prescribing, you need to consider comorbidities, both that might affect pain perception, other psychological issues, but also age, metabolism, renal clearance, any liver disease, but chronic lung disease, heart disease, and hypertension. And then think about other issues that might affect the patient. You know, can they drive to work under the influence? Can they work at work safely under the influence of an opioid? And then if you finally decide you're going to prescribe, then stick to the short-acting. The long-acting and extended release really are not made for chronic pain. If they have any use, it's for cancer-related pain. And then stay low, slow, short, and in terms of duration and quantity, and then see the patient back frequently, and discontinue prescribing at the soonest possible date. If for whatever reason you believe you have to continue prescribing, then in addition to the opioid agreement, you're really going to need to look at taking some educational training in the REMS program that's available, but also you're going to have to start doing urine drug testing periodically, and then you should be making weaning and dose reduction efforts, ideally once a quarter, but at least a couple of times a year. But hopefully you'll have very few patients that have to be managed in this way. So starting to wrap up here in terms of red flags. So some of these things are what we were taught in medical school. For me, it was 40 years ago. It's hard to believe. But you know, if you look down in the lower left-hand corner, so you know, the dog ate my homework. You know, the dog ate my prescription. I fell into the toilet. Somebody stole my prescription. Those are all red flags. They were red flags 40 years ago. They're still red flags. Early refills, canceling visits, rescheduling, then canceling again. All kinds of reasons why they can't make it in, but please call in another prescription, or please write another one so a family member can pick it up. All red flags. Patients who request opioid only and don't want anything else, that's a red flag. If you're prescribing an opioid only for the injury or pain disorder and nothing else, that's a red flag actually for yourself. Say, whoa, what am I doing? Maybe I should think twice about this. Multiple opioids, again, you know, there was great fanfare of going from immediate release to extended. So let's put people on extended. That'll cover their pain. Then when they have breakthrough pain, then we'll cover them with a short-acting pulse dose. That's really not necessary in, you know, probably only 95 to 99% of patients, and yet I would caution almost uniformly against such prescribing, except in rare circumstances. And then progressively increasing MED or MME without true functional clinical improvement. And I will almost guarantee you that as you increase the MME or MED, you will see no improvement in functional improvement except in rare cases. And if anything, you're going to have patients who become more sedated, less functional, and they will develop tolerance and start complaining about more pain, which is also a side effect of increasing the opioid dose. On the right side of the slide, in the upper corner, so patients who decide, you know, that taking 2 a day or 4 a day is not enough, and increase on their own to 6, 8, 12, 20 pills, that's a red flag. And certainly anybody who wants, you know, the brand name, that's a huge red flag, because that's probably diversion to the street. Patients who say they can't live without their medication present a red flag. And certainly self-administered by the patient polypharmacy with alcohol and other drugs is a really big red flag. Drug testing, when done properly, should show the metabolites of what you're prescribing. If they show anything else, then that means patient is getting something elsewhere, be it the street or otherwise. And if it's showing nothing, that means probably most of your drug prescription is being diverted for street use. So taking care of the patient has always been a partnership, and certainly dealing with pain and treating is clearly a partnership. We really need to think about it as a team effort between us and the patient, but also their family and other medical providers in our environment. And we need to keep talking to the patient, working with the patient in a partnership way to treat their injury, but also reduce their pain medication needs. So just to have a little bit more fun here, and then talking about opioids and pharma, I threw in a few slides around medical marijuana. And you can read the slides faster than I can read them, so I'm not going to read them to you. But I think there's two messages here. One is we're in a catch-22 situation. Society has decided that medical marijuana at a minimum, let alone recreational marijuana, is acceptable. And yet the DEA has done a really nice job quashing enough legitimate research and certainly pharma research to be able to develop a USP quality product that one could be researched to develop a drug response curve and responsible manufacturing, dosing, packaging, and dispensing. And so we're stuck with literally over-the-counter medical marijuana with no clear treatment guidelines or safety guidelines. But it wouldn't take much if we at least made it Schedule 2, so that way we could actually have a legitimate industry. And should we trust Big Pharma to do it? I don't know, but I'm not sure what the alternative will be. I'm going to show you a little bit of evidence for significant efficacy, particularly as it relates to pain. But we do know that in the states where marijuana is legal, either for medical and or recreational use, drug overdose deaths due to opioids has declined by about 25%. So I don't know about your politics, and I don't know what you think about medical marijuana, because most of us have grown up in the medical world thinking, about reefer madness and medical marijuana being something that we can't really embrace. But reducing overdose deaths from opioids from 42,000 to, let's say nationally, if extrapolated to 30,000, saving 10,000 lives would be huge. So that leads to my next slide, which shows on the left-hand side of the slide, 52% of patients that use opioids for chronic pain have substance use disorder, whereas the marijuana, it's not even half that, it's about 21%. Those are the estimates currently. And then if you look at 2015 opioid deaths, so it was in 2016, it was 42,000. Here it is 33,000. Zero reported marijuana deaths. Now, that doesn't mean that some of these people that had overdose deaths with opioids and other polypharmacy didn't have marijuana on board, but no deaths reported that where marijuana is the primary cause of death. Here's a double-blind study with a legal, legitimate product called Sativex, which is available in the EU and other countries around the world. It's a spray that can be used on the oral mucosa. And this is a double-blind, placebo-controlled randomized study. And you can see, after studying these patients, pain reduction, decreased neuropathic pain, tremendous improvement in pain disability, and almost 50% improvement in quality of life based on the parameters of the study. Small study, but nonetheless, very significant in its results. This is, This is a study that was done by the Michigan School of Public Health. They actually surveyed patients at a Michigan marijuana dispensary. And you can see I have 185 patients surveyed. Again, it's not double-blind, not crossover study, it's simply an epi study. And 64% of the patients said that they were able to reduce their use of opioids, and again, the same roughly 45% improvement in quality of life using medical marijuana to treat whatever was damaging them. Okay, and so if you don't believe those studies, and I'm not asking you to believe me, maybe you should believe the national academies. Very first of the year in 2017, they published this report, and I would commend it to you highly. You can download it for free and print it out yourself, or just keep the PDF copy on your desktop or your device or whatever. So I'm showing you one slide of several slides that go through some of the conclusions. And in the interest of time, I'm only going to show you this one. So substantial or conclusive evidence. This is their highest rating of the evidence. Efficacy for chronic pain, nausea, vomiting, and spasticity. And so when people say there's not enough evidence of efficacy, I don't know what they're thinking. I don't know what they're not reading. But this report pretty much nails it for me. And with that, I'm going to stop and take questions.
All right, great. Thank you so much, Dr. Goldberg. We actually have a few questions that were coming up through the presentation, so I will start with some of those. Let's see here. Actually, I think there was one about, someone asked, if I use the PDMP and find my patient is getting the same opioid from 3 different prescribers, am I responsible in any way to report that to anyone?
My direct answer is I don't know. It probably depends on your state, but I would be, if you knew any of those physicians, you might want to give them a call. And maybe if you didn't know any of them, you might give them a call. But I don't know what the legal requirement is. That's an excellent question. You're the first one to pose that to me. I'm going to go find out, and maybe you should too. Great question. Clearly, you're not going to prescribe anything for that patient. Thank you.
Great. And then we have we have a state-specific one. Well, in New Jersey, there's been a dramatic increase in pain management centers, which routinely prescribe opioids and perform drug screening and confirmation testing by mass spectrometry. Sorry if I pronounced anything wrong. These centers are shocked that the drug testing is not more profitable, which to me means they're not doing the testing for the right reasons, like patient monitoring. Is this trend being seen nationally?
I would say yes, although it's kind of, for some states, it's kind of, this is a late trend. It's been going on in a lot of places for a long time. And so pain management, I'm going to have to be careful. There's undoubtedly pain management docs or friends of pain management docs on this call. And so, and there are a large number of very excellent and legitimate and well-intentioned and well-qualified pain specialists in my community and around the country. But it doesn't take anything to call yourself a pain specialist. It doesn't take anything to set up your own center. And if you have the skills to examine a patient, or if you have the interventional skills to do lots of injection therapy, and certainly if you can do e-prescribing or put a pen to a pad of paper and write prescriptions, and believe that you can treat pain with opioids better than anybody else, there's a huge market for that. Pain is a huge problem in this country. It costs hundreds of billions and maybe even trillions of dollars of lost productivity and expense every year, and it's the biggest healthcare issue we have, actually, and we don't have really great answers, which is why we've got 40 opioids out there, and it's a huge problem. So back to your question, the drug testing industry is a huge industry, and in a lot of cases, people are being over-tested. The technology isn't all as good as it's cracked up to be, and but there are labs and clinics who do an excellent job, but it's hard to find who they are. But I would look for those if you have to refer a patient.
Great. We had a question earlier that was, why isn't there more use of long-acting local medications for post-op pain control, such as Exparel, instead of the prescriptions given for large amounts of narcotics?
I actually don't know what Exparel is, so I don't know if we need to ask that person to type in what they're referring to. I can't answer that question right now. Do we have another question?
So, yep, we do. We have a few. Let's see here. How informed do you think the medical community is with regards to ACEs and substance use in terms of screening and patient education? And also, a second part of that question is, comments on harm reduction models that we're seeing in places like Portugal, Vancouver, internationally.
Oh, I think physicians are just in the early education phase, and I mean, that's why I'm doing this talk. That's why I do it around the country. That's why I did it for Jefferson earlier in the year. We are the problem, but we're also the solution, and we've been duped since the mid-90s as a profession, and we were told specifically that OxyContin had a low risk of addiction, had low side effects, and you could give almost any significant dose for as long as you needed to, and then you could stop it at any time. Of course, that wasn't true, and the so-called study was like a letter to the editor that somebody wrote in the 80s, and that kept getting repeated and became, mythology or theology. So physicians in general, as they're really getting, hit in the face with this epidemic, are starting to pay attention. Various state medical associations, I know the California Medical Association is really taking it seriously. It's putting on all kinds of CME. The problem we've got is that we have chronic pain patients already on opioids, and we have new patients getting hurt and developing pain disorders every day. And the studies show that it takes about 7 years for new literature and CME to actually change the behavior of most treating docs in this country. And so we don't have 7 more years. But I'd say we've been beginning. I've been fighting this battle in my role at Healthesystems for the last 5 years. And I can actually anecdotally, the company that I was the CMO for prior to Healthy, one of our clients was a Pennsylvania-based Blue Cross Blue Shield plan, and their primary interest was having me and my company manage the physical medicine services. But when we looked at their data, I could already see 8, 9 years ago this huge problem with opioids, particularly around hydrocodone and Vicodin. And I actually proposed to them an intervention program, and they said, "Oh no, we don't need that. It's not a problem." And physicians would rebel if we started telling them they couldn't prescribe a second prescription or refill of hydrocodone and Vicodin, because everyone thought these were benign medications, but clearly they're not. So long answer, but I think we're just in the beginning phases of recognition leading to education and intervention.
That's great. And then we had a follow-up about the Exparel. So Exparel is a longer-acting local anesthetic lasting 36 hours and provides pain control for post-op patients. Exparel has been used in University Hospital with good response, then taken out of formulary due to cost.
Okay, I'm assuming it's in the lidocaine family. So I would say so there are some lidocaine patches still, but typically they have to be changed fairly frequently. Unfortunately, I don't know why, other than cost, why they've taken out of either Jefferson Hospital or elsewhere. Cost probably is the issue, particularly when you get to ACOs and capitation DRGs. That may be the issue as opposed to clinical. That's all I can say about it, probably.
Great. And then, so another question that came up was, how do you address or talk to other staff members, either superiors or coworkers, who do not understand the opioid epidemic and addiction, especially when vocabulary such as druggies or bums are used?
It's hard. I mean, just getting my colleagues and our clients and docs that we deal with just to leave the word narcotics. I mean, narcotic is a loaded term, you know, from the 60s, you know, when the BNDD turned into the DEA, and you know, narcotic is any dangerous substance, you know, opioids and others that are classified. We need to be talking about opioids, and we need to understand. And I think that the biggest thing is it's a shift between thinking of people as druggies to thinking that people actually have a physical and psychological disorder. It's really no different, you know, than any other chronic disorder. You know, people still look at alcoholics, you know, as alkies. Well, I guess some doctors do, but you know, we should be looking at people as having substance abuse disorders, you know, dependency disorders, addiction disorders, who need the same compassion as somebody who has, you know, chronic pain or you know, chronic any condition that we treat with compassion. It's a hard battle, but with the epidemic killing 40-something thousand patients a year, we have to do everything we can to push back, and sometimes I think we have to do it one colleague at a time.
Great. Thank you so much, Dr. Goldberg. I think that's all we have time for. We have a few more questions, but I'll compile them to send to you, and we can get to a few of them offline. But I wanted to thank you again for joining us this evening, leading this presentation. And I want to thank everyone who joined us tonight as well. The presentation has been recorded, so we will put that on our YouTube and send a link out to everyone who attended. And, you know, if you had any friends that are registered and unable to make it, they'll still be able to watch the presentation with the link. But again, I wanted to say thank you to everyone so much for joining us this evening.
All right. Good night, everybody.